Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Deschambault. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. May I come in?
Yes, please, be seated. May I know your problem?
Well, I'm a patient with marginal B-cell lymphoma, for which I had a splenectomy 2 years ago. But last year I developed a diffuse large B-cell lymphoma that was treated with CHOP reduction. The disease again went into complete remission.
Okay, then what happened now?
I was doing well until recently, a few days ago, late last week, when a swelling developed on my left testicle. I had fevers and chills for the past few days, and I felt weak.
What's your age?
45, doctor.
Do you drink or smoke?
Well, I used to smoke and drink, but I quit completely.
Your previous illness and surgeries?
I had B-cell lymphoma and diffuse large cell lymphoma. I had splenectomy.
Are you taking any medications?
No, doctor.
Are you allergic to any medications?
No, doctor.
May I know your family history of illness?
Well, my mother had paralysis before she died at 70. My father is deceased at the age of 84 of a head and neck cancer. My 56-year-old brother with type 2 diabetes and blindness, secondary to diabetic retinopathy. My 41-year-old younger brother has hypertension, and my younger sister has thyroid disease.
Okay, well, as per the laboratory data, your white blood count is 13.8, hemoglobin 14.3, hematocrit 42.4, platelets 235,000, SMA7 shows a potassium of 3.9, glucose is 213. Physical examination shows no conjunctival pallor or Icarus, no adenopathy, no corticoid bruits, lungs are clear, no gallop or murmur in heart. Your right testicle is markedly erythematous and swollen and tender. Endocrine shows symptoms of type 2 diabetes mellitus. You have left testicular swelling. It is tender. Etiology, possible epididymitis, or possible torsion of the testes. You have a history of diffuse large cell lymphoma and remission. You have a history of marginal B-cell lymphoma. Status post-splendectomy 2 years ago. You have a history of diabetes mellitus. I recommend that you have the ultrasound tests done for scrotum and abdomen. I will ask for CT scan of abdomen and pelvis after seeing the ultrasound reports. I am prescribing IV antibiotics. See me once you receive the ultrasound test reports.
Extract 2. Questions 13 to 24. You hear a physician talking to a patient called Mr. David Goggins. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, Doctor. Good morning.
Good morning. May I know your problem?
Well, I'm getting frequent nausea and vomiting with an aspiration pneumonia and abdominal discomfort. I had an endoscopy which revealed a small ulcer after dropping my hematocrit. Now I feel anemic. I had a CT scan last week that showed pneumatosis and my cecum worrisome for ischemic colitis, bilateral hydronephrosis and multiple liver lesions. Yesterday I had multiple bowel movements and passing flatus and had epigastric pain.
Okay, what's your age?
67, Doctor.
Do you smoke or drink?
I have a chronic alcohol use, but I've stopped smoking long back.
Tell me your past medical history.
I have chronic obstructive pulmonary disease, history of pneumonia and aspiration pneumonia, osteoporosis, alcoholism, microcytic anemia.
Well, your physical examination shows you are afebrile. Your heart rate is in the hundreds to 120s, at times with atrial fibrillation. Respiratory rate is 17 to 20. Blood pressure 130s to 150s and 60s to 70s. Your abdomen is distended with tenderness mainly in the upper abdomen but very difficult to localize. The CT scan shows pneumatosis in the cecum with an enlarged cecum filled with stool and air fluid levels with chronically dilated small bowel. There is a possibility of ischemic cecum with possible metastatic disease, bilateral hydronephrosis on atrial fibrillation, aspiration pneumonia, chronic alcohol abuse, acute renal failure, chronic obstructive pulmonary disease, anemia with gastric ulcer. I would recommend getting a repeat CT scan to assess it further to see if there's worsening pneumatosis versus resolution to further evaluate the liver lesions and make decisions regarding planning at that time. Since you have frequent desaturations secondary to your aspiration pneumonia and any surgical procedure or any surgical intervention would certainly require intubation that would then necessitate long-term ventilator care. So I will look at your CT scan and make decisions based on the findings.
That is the end for Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the best answer, A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at the question 25. You hear a discussion between a nurse and a physician explaining about different types of breath sounds. Now read the question.
Hello, doctor. Can you explain what are the different types of breath sounds?
Well, there are several distinct types of abnormal breath sounds. Crackles, also called rails, tend to sound like discontinuous clicking. Bubbling or rattling when the person inhales, crackling breath sounds may sound dry or wet, and physicians might describe them as either coarse or fine. Stridor is a high-pitched, harsh, wheeze-like sound that occurs while breathing in people with a blocked upper airway. Wheezing noises are high-pitched and persistent that may sound like a breathy whistle. At times, wheezing can be loud enough to hear even without a stethoscope. A short version of a wheeze, called a squawk, occurs during inhalation. Ronchi are persistent, lower-pitched, rough sounds similar to snoring.
Question 26. You hear a monologue by a physician explaining about Heberdine's nodes. Now read the question. The bony growths that develop on the finger joints are called Heberdine's nodes. or interphalangeal joints. Mostly, Heberdine's nodes develop on the joints nearest to the fingertips, causing the fingers to appear crooked. They only develop in osteoarthritis patients. Each joint in our body has a layer of cartilage to protect the bones. Osteoarthritis causes the cartilage layer to degrade, gradually allowing the bones in the joints contact directly with each other. Over time, the bones get damaged from scraping together. Our body reacts to this body damage by developing new bones that are known as nodes. Heberdine's nodes are one of such bone formations on the fingers of patients with severe osteoarthritis. Question 27. You hear a discussion between a nurse and a physician explaining about surgical treatments for patients with a desiccated disc. Now read the question.
Hello, doctor. What are the surgical treatments for patients with a desiccated disc?
There are many different surgical treatments for a desiccated disc. In the method called fusion, the vertebrae surrounding the desiccated disc will be joined together to stabilize the back and prevent movement that will worsen pain, causing discomfort. In the decompression method, the extra bone or a disc material that has moved out of place is removed to make more room for the spinal nerves. In the correction method, the surgeon will make the necessary repairs to correct an abnormal curvature of the spine to relieve pain and increase range of motion. In the implant method, artificial discs, or spacers, will be placed in between vertebrae to prevent the bones from rubbing. Question 28. You hear a discussion between a nurse and a physician explaining about outcomes of TB skin test. Now read the question.
Doctor, can you explain to me the outcomes of a TB skin test?
Well, the outcomes for TB skin tests are not always clear-cut. The main consideration in a TB test is the size of the bump on the arm. If the bump is smaller than 5 millimeters, then the test result is considered negative to TB. In a case where the test bump is larger than 5 millimeters, then the test result is considered positive. But we have to be very cautious about false positive and false negative. At times, patients vaccinated against TB using the Bacillus calmette-guerin can show a false positive result for TB. There is also a possibility that when the patient's infected with bacteria similar to TB, false negative result happens when a person has a weak immune system or has been exposed to pathogens, such as smallpox or measles. Patients infected with TB very recently and very old TB patients can also show false negative test results. You hear a monologue by a physician explaining about atelectasis. Now read the question. A partial or complete collapse of one or both the lungs is called atelectasis. That occurs when tiny air sacs in the lungs, called alveoli, deflate. The collapse of the lowest lobes in both the lungs is called bibasilar atelectasis. The lobes of the lungs are filled with millions of tiny sacs, called alveoli, which are arranged in clusters and surrounded by blood vessels. When a person breathes, the alveoli allow their blood to collect oxygen and exhale carbon dioxide. During bibasilar atelectasis, the alveoli in the lower lobes of the lungs deflate and stop performing this crucial task, therefore blocking oxygen from reaching the vital organs, life-threatening at times. Question 30. You hear a discussion between a nurse and a physician explaining about liver flukes. Now read the question.
Doctor, what are liver flukes?
Liver flukes is a parasite disease. A patient may never know he has liver flukes. Even the doctors at times may not diagnose the condition because the symptoms of fasciolasis are similar to many other conditions. There are chances that a person with liver flukes living may never develop fasciolasis. Others may develop fasciolasis many years after the liver flukes entered the body. A person cannot transmit liver flukes accidentally to someone else, unlike other parasite diseases. Liver flukes make their way from the intestines to the liver once it enters the body. To get into the liver flukes must burrow through the lining of the liver, causing pain in the upper right abdomen. The two types of liver flukes that can affect people are fasciola hepatica and fasciola gigantica. That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a senior doctor and junior doctors about volvulvus. You have 90 seconds to read questions 31 to 36. Hello everybody. I am going to explain to you about volvulvus. The word volvulvus is derived from the Latin term. It is a subtype of abnormal gastrointestinal rotation. In volvulvus, a loop of intestines is twisted at a point along the mesentery, attached to the gastrointestinal tract. Volvulvus may result in bowel obstruction that is considered as a medical emergency. Because there is not a blockage, but there is also a compromised vascular supply to the gut. There are 4 primary mesenteries found within the abdomen, and as a result of it, there are 4 corresponding primary types of volvulvus: gastric, midgut, cecal, and sigmoid volvulvi. Gastric volvulvus occurs when our stomach twists at least 180 degrees around its mesentery, resulting in obstruction of the bowel. Patients with gastric volvulvus may be present with Borchards triad, which are spontaneous and severe epigastric pain, uncontrolled producing vomiting, noises without a vomit, due to the impossibility of passing a nasogastric tube through to the gut. There are two subcategories of gastric volvulus. Organoaxial volvulus tends to occur after traumatic events or hernia of the periesophageal area. The stomach rotates along its long axis, that is along the path between the pylorus and the cardia. This condition is usually symptomatic when the rotation is more than 180 degrees and causes ischemia in addition to obstruction. Mesenteroaxial volvulus tends to occur very frequently in children. The rotation of the stomach along its short axis, that is along the path perpendicular to organoaxial, or the pathway between the lesser and greater curvatures of the stomach. The treatment of gastric volvulus, which may involve an emergency laparotomy, insertion of gastrostomy, percutaneous tube, and hernia and diaphragmatic damage repair. The surgery is primarily aimed to reduce the degree of twisting and prevent any chances of recurrence while taking care of factors that create a predisposition. Midgut volvulus begins in newborn with sudden bilious vomiting. In addition, the abdomen becomes tender as it fills with fluid that accumulates within the bowel lumen, and followed by inflammation of the peritoneum and shock. Patients with midgut volvulus typically have a corkscrew sign visible on fluoroscopy, contrast examination, which is a spiral appearance of the bowel. Another imaging technique, such as ultrasound and computed tomography, show a whirlpool sign, which is used to denote twisting of the bowel on itself. A LAD surgical procedure is done to treat midgut volvulus, which entails dividing the tissue that creates an attachment between the cecum and the abdominal wall called Ladd's bands, widening the mesentery of the small intestines, removal of the appendix and proper placing of the colon and cecum. Patients with sigmoidal volvulus often have abdominal bloating, constipation, and nausea that may or may not be accompanied by vomiting. Sigmoidal volvulus is considered to be associated with neurological pathologies such as multiple sclerosis and Parkinson's disease. The causes of sigmoidal volvulus include the South American Chaga disease, laxative use, and diets rich in fiber. A whirlpool sign is also seen in sigmoidal volvulus on imaging. In addition, a coffee bean sign may be seen on the abdominal X-ray that will look like an inner tube that is bent. In most of the cases, the insertion of a rectal tube is found to be successful in treating sigmoidal volvulus. Cecal volvuli are predominantly associated with two predisposing factors: lack of thorough peritoneal fixation and fulcrums such as abdominal masses or adhesions. Patients with cecal volvuli tend to have distended abdomens in addition to colicky, abdominal pain, and vomiting. Nearly half of the patients with cecal volvuli tend to have a cecum that is abnormally rotated in an axial plane, while the remainder have a cecum that inverts in addition to twisting. Treating cecal volvuli may involve laparotomy, hemicolectomy, or cecostomy.
Now, look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of gangrene. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain different types of gangrene?
Well, the term gangrene refers to the death of tissues due to lack of blood supply and deeper invasion of infected tissues, which are broadly classified into two categories, dry and wet gangrene. Although there are many types of gangrene, all types of gangrene manifest either as dry or wet form. In the dry gangrene, there is obstruction or slowing of blood flow into the organ or part of the body that is affected. Peripheral parts like toes, fingers, nose tip, earlobes, etc. are commonly involved. Often, dry gangrene is seen in patients of type 1 and type 2 diabetes, where long-term high blood sugar damages the small arteries and blood vessels that supply blood to the end parts of the body, such as fingers and toes, resulting in obstruction and slowing of blood flow and ultimately gangrene. In patients with dyslipidemia or high cholesterol, there is a risk of cholesterol deposition and lipids called plaques within the blood vessels. In the peripheries, such as fingers and toes, this leads to decrease in the blood vessel diameters by narrowing of the lumen, resulting in formation of gangrene. Patients with peripheral arterial disease develop fatty acid deposits or develop narrowing of peripheral blood vessels. Certain conditions include scleroderma and Raynaud's disease, where the blood supply is restricted to leg or hand muscles, resulting in gangrene. Dry gangrene is usually identified by cold, painless, and dry and shriveled up affected part. However, there will be healthy skin surrounding them. The area affected appear mummified. Wet gangrene occurs due to infection and invasion of bacteria into deeper tissues after injuries, foot ulcers, frostbites, or burns. There is excessive swelling of the affected part due to release of the toxins from the invading bacteria, resulting in blockage of the blood supply and worsening of the infection as the white blood cells cannot reach the area affected via blood vessels. Wet gangrene spreads much quicker than dry gangrene and may result in life-threatening complications like septic shock. Wet gangrene appears discolored or black, and often with acute and excruciating pain. There are black blisters and foul-smelling pus beneath the thinned skin at the area. Since the infection is associated with discharge of pus, it is called wet gangrene. Gas gangrene is caused by bacteria called Clostridium that is found in spores present in the soil. Gas gangrene was a common cause of death in the wars. The gangrene is caused by the toxins released by the bacteria. Gas gangrene is further categorized into three types: traumatic gas gangrene, occurring after injury; non-traumatic gas gangrene; recurrent gas gangrene, caused by C. perfringens species of bacteria. Necrotizing fasciitis is a deep tissue infection caused by bacteria like Staphylococcus or Streptococcus. The bacteria spreads deep into the skin and into the tissues and attacks the soft tissue and the fascia, which is a sheath of tissue covering the muscle. This can occur in an extremity following a minor trauma or due to the opportunity for the bacteria to enter the body, such as surgery. The necrotizing fasciitis infection, known as flesh-eating bacteria, is most common with minor trauma. A mixed bacterial infection is often the cause after surgery. Internal gangrene is caused when blood supply to an internal organ is hampered, usually by pressure from another organ or growth. For instance, in hernia, there is an abdominal opening where the intestine may get blocked, and the blocked area turns gangrenous. Noma or cancrum oris affects the face. Fournier's gangrene is a rare but life-threatening condition affecting the penis and genitalia. This disease has been shown to have a predilection for patients with diabetes as well as long-term alcohol misuse. However, the disease can also affect patients with non-obvious immune compromise. The development and progression of the Fournier's gangrene is often fulminating and can quickly cause multiple organ failure and mortality. Due to such potential complications, it is crucial to diagnose the disease process as early as possible. Death rate is very high despite antibiotics and aggressive debridement and broadly accepted as the standard treatment. Mullany's synergistic gangrene is a rare type seen in patients after surgery. Mullany's synergistic gangrene is caused by S. aureus and Streptococcus organisms. One of the recognizable symptoms is the presence of extremely painful lesions that usually form in the second week after surgery or minor trauma. That is the end of Part C. You now have 2 minutes to check your answers.